I'd like to invite the chairpersons for this session. Dr. Devendra Singh, gastroenterologist, senior consultant gastroenterologist from Apollo Hospital, Bilaspur. Dr. Amit Thabrani, gastroenterologist from Thabrani Gastro and Liver Clinic, Gwalior. And Dr. Romesh Chavlani, gastroenterologist and hepatologist from Gastro and Liver Care Hospital, Jabalpur.
Good morning, everyone. Well, upgrading skill, who better than Mohan Ramchandani to talk about it? We have seen you grow like anything, you know. Now you are practically invited everywhere, all across the world, to demonstrate your skills. And we are so proud of you.
Thank you so much, sir. Thank you so much. And at the outset, I thank Dr. Sanjay and my warm regards to my teachers, Dr. Chaubal, Dr. Loya, under whom I did my undergraduation. And so today I thought I'll try to go to the basics. All of us are doing endoscopy, but are we doing it correct? As Dr. Devendra Singh said, the world is so small, we travel all across the world and see how much lagging we are behind the countries like even China and also like South Korea, Japan. Most of the endoscopy are done by the clinicians, and they are able to pick up cancers which are in very early stage. Previously, I had a misconception that they have a screening program, so that those who have a screening program, they call the patient when they are asymptomatic and they do endoscopy and they can pick up. But then once we saw the studies, majority of the cancers which are early in stage are picked up by the routine endoscopy, during the routine endoscopy, not during the screening program. So that means the standardization of endoscopy is not there, and we must work on this, and we must follow certain rules to do endoscopy. So what are those, and how we can bring this discipline in our clinical practice so that we can have a better answers. So I'll start from here. It's not coming? Okay. So now, okay. So how to improve this diagnostic endoscopy? So there are three things. What are those three things? So I'll be talking about these three things. One, very important. As we prepare the colon, we must prepare the upper GI endoscopy. Unless you prepare, you are not going to pick up cancers, or leave alone you may miss many things. You must have a small knowledge about high definition white endoscopy and also the narrow band imaging. Not very advanced, just basic. And you must have sufficient time, at least 7 minutes to do endoscopy. You should not be hurried. If you follow these three rules, I am 100% sure that you will start picking up the cancers, which now we are also picking, and I'll show you the examples. So what is the preparation? So preparation is either you allow the patient to drink water up till 2 hours of the endoscopy. You should not ask complete fasting from the overnight, and they are allowed to drink water. And very small change. One is keep a half tablet of N-acetylcysteine, which is available, and Semethicone, which are the drops, the pediatrics drops, which are easily available, because one is a mucolytic and other is an anti-foaming agents. So if you do these two, you will have a very nice picture. Now, the pictures can be more simplified way is fasting after dinner, okay, clear liquids allowed, and 160 milligram of, like 4 drops of Semethicone in water. So this is the welcome drink which every patient now received at AIG. What we do is we keep this N-acetylcysteine, which is a mucomix, everybody might have taken during COVID time. This is a mucomix tablet, half tablet, or we make a jug full of water, and based on the calculation, we add diamol drops and mucomix. So these are the combination of these two drugs and simple water. This patient will take around 1 hour, 1.5 hours before the procedures. And see the difference. You can see if you have such type of mucus attached to the mucosa, you will never be able to diagnose anything. You can do a macroscopic examination, okay, there is no obstruction, there is no advanced cancer, but what? Our 5-year survival rate of cancer is 30% in stomach and 20% in esophagus. So we are now discussing about palliation, putting this stent, putting a GJ stent, but no, we should work on something else where we can, our diagnostic things can be such that we can diagnose the cancer in the mucosa when the cancer is still rising and still developing and not yet crossed the mucosa or mostly submucosa. And this type of preparation has been shown scientifically that if you do that, your preparation, even the semithicon, even the simple semithicon improves visualization score of the stomach and duodenum very well. Unless you have a good visualization, you forget that you are able to do a good. So the optimal preparation is very important. And then also important is systemic observation. Don't jump. And also try to report endoscopy in a more uniform way. Like suppose somebody is doing endoscopy and say there is a ulcer in the mid-esophagus. And then it goes to Dr. Kumar and he says, where is the mid-esophagus? We don't know. So we must know what is upper esophagus, what is mid-esophagus, what is anterior, what is posterior. And if we document that, our colleague who is seeing far away, or if we are following, suppose there is a Barrett's esophagus and there is a dysplasia at an anterior wall, a person should know where is the anterior wall. So let's see how we describe upper esophagus, lower esophagus. So if you see endoscopically, there are two more constriction. Once we are doing live demonstration, we'll show you also how a left bronchus makes an impression on the esophagus. And similarly, a right atrium makes an impression on the esophagus. So anything above the left bronchus between the post-cricoid and left bronchus impression is the upper esophagus. So anything from here to here. We don't see the aortic arch. So we see the left bronchus impression in the esophagus, endoscopically also. And also from the left bronchus to the right atrium is the mid-esophagus. And from the right atrium to the G junction is lower esophagus. So this documentation has to be there. Vertically, we know the length of esophagus. We cannot say a person who has 35, the length like 32, 33 may vary from patient to patient, but this will remain same. So always make a uniform diagnosis as far as length is concerned. Then come to what is anterior wall, what is posterior wall. Once the patient is in the left lateral position, and if you spray water, it will gravitate down to the left because the patient is in the left position. So anything which is at wherever the water drops is the left quadrant, and bang opposite will be the right quadrant. So this is the left of the patient. Patient is in the left lateral and you find an ulcer over here, don't write 6 o'clock. Write left wall of the esophagus is showing an ulcer, or the right wall of the esophagus. And then you can make a diagnosis by posterior wall. If you see the spinal bulges, the vertebral bulge is posterior. So if the patient is in the left position, you see the gravity by the water, which is the left, right, and posterior, and then anterior. So this is how you make. Also, you must know all the walls. Like here, you know now that this is the left, this is posterior. But on stomach, as soon as you enter the stomach, you will you see that these rugae or the gastric folds on the greater curve. So 6 o'clock is the greater curve, and incisura on top is the lesser curve. This is the D is the anterior wall, B is the posterior wall. And as soon as you enter into the duodenum, you are in the long position. At that time, you will have a superior wall, inferior wall, then anterior wall and posterior wall. If you have an ulcer on the posterior wall, they are more prone for bleeding because there is a gastroduodenal artery. While ulcer on the anterior are more prone for perforation because they are open to the peritoneum. Next is the peritoneum. So we must describe where is the ulcer, anterior wall, posterior wall, superior or inferior. Similarly, once you withdraw the scope from the second part of the duodenum, the things again change. There is a medial wall, there is a lateral wall, this is superior wall, anterior wall and a posterior wall. So these are very important landmarks to understand, because we will report like this: upper esophagus, mid esophagus, anterior wall, posterior wall. So this is the most important. I mean, I would have loved more residents to be here, but even if we are late in the practice, we must adopt this good things. The air is also important. Sometimes we are in hurry and we don't insufflate stomach with full air, and everything is collapsed and you will miss something. And if you allow this air to go, you will see there is a crater of the ulcer over there, which was completely hidden once you did not give much time. So not only the time, but also proper air insufflation is important. And one must take the photographs. So in Japan they take 22 photographs, but it is too much. I think we must take at least 10 photographs, starting from proximal esophagus, distal esophagus. We must document the Z line, then the greater curve, lesser curve, retroflexion, and then incisura is very important to see, because gastric atrophy starts from here. If you don't know gastric atrophy, you will never be able to diagnose cancer. So I'll tell you how to diagnose this. But one must see how to map the stomach. This is the stomach with the gastric antrum, then D1, D2, see the papilla, all pictures from the esophagus, upper, middle and then Z line, retroflexion in the fundus, then forward view in the body, retroflexion just top of the incisura, then retroflexion at the incisura, then antrum front view, D1, D2 and papilla. If you do that, you will not miss anything. These are the Japanese criteria. I think it's too strict, so we should not go into that detail. Once we are seeing fundus, we must also know the landmarks. We just cannot say this is the fundus. Now so fundus has got a deep part which is firmly attached to the diaphragm. This A part, which is known as fornix. So this is the fornix, and anything near the scope in the retroflexion is the cardia. So this is the gastric cardia, the F part, and the A is fornix. So we must describe a patient who has say for example gastric cancer, or I'll come to the details of Sievert's classification, why they are important to know which is gastric cardia, which is fornix, which is anterior wall. And we must be aware of 4 or 5 good classifications. The Los Angeles everybody use. The Prague classification, unfortunately we don't have much of Barrett's in this, but we must use Prague classification for Barrett's. And the G junction should always be defined. This G junction, how lax the LES is. So if you can see here, the gastric folds which approach from the body to the cardia is known as gastroesophageal flap wall, GEFV. So if this flap wall, the 2 folds which approach from body to the scope are intact, then it is either Hill's grade 1 or grade 2. But if you insufflate the air and there is a gap here and those folds disappear, this is Hill's grade 3, and then hiatus hernia comes. So any endoscopic treatment will not be effective here in these 2 for a reflux, because you cannot repair the hiatus defect. You must have a laparoscopic approach where hiatus repair is also done. But here you can do many endoscopic procedure like GERD-X, or you can do ARMA, where if you constrict this mucosa, even the muscle to muscle approximation, you need not to have a hiatal repair. So if your report is showing the Hill's grade of G junction, that means you are quite meticulous in your endoscopy practice, and even if our surgeons see these endoscopy report, they can decide about the treatment. Also, always we must describe the ulcers, which we do always, like Forest classification. And these polyps, whenever you see a polyp, don't rush like a polyp. You always should write what is the Paris classification of the polyp. Now, the Paris classification, the polyp can be pedunculated when it is called 1P variety. Or if the polyp can be sessile when it is called 1S variety. The polyp can be flat and slightly risen is 2A, when it's completely flat is 2B, when it's depressed type it's 2C, or there is a complete excavation, there is known as type 3 variety. So any cancerous lesion which is type 3 or 2C, they are more dangerous and may require more bigger intervention like surgery, while these other polyps can be removed endoscopically. We will talk about that also. So these are some of the classification we must use. Just don't say polyp. So from now, if we see a polyp in the stomach, we must describe what is the Paris classification, what is the position, whether it's on greater curve, lesser curve, anterior wall, posterior wall, and this type of description should be there so that a uniformity can come. Sievert's classification is commonly used for GE junction classification, because if the GE junction cancer is predominantly occupying only the esophagus and not even covered the GE junction, it goes for thoracoscopic esophagectomy. While if the GE junction cancer is not yet involved the esophagus GE junction and predominantly in the stomach, is known as Sievert's 3 and requires total gastrectomy. Between 1 to 2 centimeters, that depends on what type of esophageal and gastric involvement is there. So this type of reporting will change the practice, because our surgeons will be able to know what type of surgery they have to plan. So all the GE junction cancers should be reported in Sievert's system. The classification of esophageal varices are rapidly changing. Now the classification is small or large, less than 5 millimeter, more than 5 millimeter, and this is the typical syringe classification of the gastric varices must be reported in this way. When it comes to take a biopsy, you must take with the protocol, always. If you are suspecting Barrett's esophagus, take by Seattle protocol. Means every 2 centimeter you have to take 4-quadrant biopsy. Keep on coming up every 2 centimeter, you take Seattle protocol biopsy. While if you are suspecting gastric atrophy or intestinal metaplasia, there is a Sydney classification. Once you take biopsy from the incisura, 2 from antrum, 2 from, if you are suspecting celiac disease, always take 4 biopsy. 1 from D1, 3 from duodenum. If you are suspecting eosinophilic esophagitis, take 3 from lower part and 3 from upper part. So this is how the biopsy protocol is there. You should not leave this like 1 biopsy and otherwise you will, because celiac disease is a patchy disease. You may miss a celiac, your biopsy, 1 biopsy is negative, you say, okay, this is not celiac. But in fact it is, because if you have taken 2 more biopsies from different place, it would have picked up. So that is why these protocols are there to avoid false negative results. So this was about systemic examination. We saw how to prepare a patient to make it completely visible, all mucosa visible. Then we went inside with a systemic approach, esophagus, stomach, complete examination, D1, D2, papilla. So you will not miss much. But now we must see how do you do good white light endoscopy and how to interpret narrow band imaging. This is not a very detailed narrow band, but we must know how a normal mucosa of stomach look like. If you know normal, you will quickly know the abnormal. So systemic observation method will look like for the normal mucosa. We must see how a microvascular pattern is seen, how microsurface pattern is seen. Then we must photo document. Now come to the normal mucosa. So if you take a biopsy from gastric corpus, you will see the glands. The gastric corpus is a very busy mucosa. It produces pepsin, it produces HCl, it produces mucus. So a lot of glands are there. All glands will open to the surface by a orifice. So this orifice should be seen If you see this, these are the dots where the glands are emptying into the lumen, and these dots should be seen. And this is how it is seen in white light endoscopy. So this is the RAC, regular arrangement of collecting venules. If you see this, you rule out H. pylori. So important. If you see a normal pattern of this type of RAC, the regular arrangement of collecting venules, this is just white light endoscopy. Then you must switch to the narrow band or whatever image enhanced endoscopy you are using. You must do, even if it is a BLI or whatever image enhanced you are using, you must have a proper assessment. A cap is a must. A black hood cap is very important because it keeps the mucosa at a constant distance from the lens. If mucosa is firmly attached to the lens, nothing will be seen. So it's like a retractor. It keeps the mucosa away. But suppose this is the lesion and you are going and seeing with a hard cap, you will injure this. If you injure this, there will be bleeding and whole a narrow band or BLI will get spoiled. You cannot see anything. So always use a soft cap. As soon as you arrive to the lesion, you press the scope down, do small suctioning so that everything comes inside touch the cap very gently. And once you do this, this type of mucosa will be seen. So these are the mucosa which I was talking about. It's like a histology picture. It's like a histology. You can see these holes. These are crypt openings. And these crypt openings, and these greenish big vessels are RAC. If you have a round crypt opening and RAC seen, it is normal. Most of the time. Don't go into the most detail, but if you go into some details, you will see the crypt opening, and then these cyan color vessels are RAC, and then there are other vascular structures like this is known as SECN, that is the vessels which surround the crypt, that is a subepithelial capillary network. And the white area between these two is the marginal crypt epithelium. So this is about corpus. So whenever you see this type of mucosa, this is the corpus. Hole, then white surrounding structure, and then there is a SECN. So this is how the normal will look like. And as we go into the antrum, the antrum is slightly different. So there are no direct opening. It's a branched opening. So the crypt orifice will not be seen. Only the vessels will be seen. So the normal antral mucosa will look something like this. There will be no crypt opening. There is a branched vessels, and this is the normal. So once you know this is the normal, then you come to as soon as you see this is the normal gastric corpus mucosa, this is normal antral mucosa. So this you keep in mind. Once we discuss more, I'll take 10 minutes more to discuss in some details what we are doing and how to diagnose gastric atrophy. Now once you know this, identification of high risk patient is important. H. pylori is very common, and H. pylori cause acute gastritis first, then it leads to the chronic gastritis. Like there is a acute gastritis. When there is H. pylori, there is neutrophils, which is then substituted by chronic gastritis once you have lymphocyte. Once this phase over, then it comes gastric atrophy. And then once atrophy is taken over because once the normal gastric mucosa is gone, a specialized epithelium take over. Intestinal mucosa takes over. So that is known as intestinal metaplasia. And if the intestinal metaplasia is then convert into dysplasia and cancer. So if you want to catch cancer, you must know how the H. pylori looks like. In majority of the cases in our country, in other countries also, it is the H. pylori which causes this type of cancer, and we are not diagnosing them. So loss of appropriate glands, vanishing of glandular unit is known as atrophy. How to diagnose atrophy? So you can see here the endoscopically atrophy. Can you see the difference here? One is loss of gastric folds here, and two, there is increased visibility of these vessels, which is not seen on the left side. So there is increased visibility of vessels, less gastric fold and pale mucosa. Three things. So if you find this, you will be able to diagnose gastric atrophy. Suppose you are able to diagnose gastric atrophy once you have done a proper preparation, insufflated stomach, cleaned the stomach and you have sufficient time, you will be able to diagnose atrophy. And once you diagnose atrophy, classify it. The atrophy usually starts from the gastric antrum. So the first you can see here, the pale mucosa is limited to gastric antrum. Then it climbs up to the incisura towards the lesser curve. So once you retroflex at the lesser curve, you will start seeing this pale mucosa. And then it ascends towards the cardia from the lesser curve. Then this is known as gastric atrophy. So this is closed type, C1, C2, C3 variety. This is known as Kimura Takemoto classification. Everybody should learn this. And then once the lesser curve is occupied, this line descends down towards the greater curve. So this is gradually, it involves anterior wall and then complete atrophy happens. And then intestinal metaplasia, then cancer. So this is how the atrophy now converts to gastric intestinal metaplasia. Now you can see this is always within the atrophic area. And you will start seeing this type of islands, white or reddish mosaic color islands or flat or depressed areas within the atrophy. So this is gastric intestinal metaplasia. And this is how it looks like, and if you zoom there, you will start seeing intestinal epithelium like this. And sometimes the magnification endoscopy will show light blue crest, or because this is intestinal metaplasia, it absorbs fat. Normally gastric epithelium does not absorb anything, but if it converts into a specialized epithelium, it starts absorbing the fat. So this is known as white opaque substance. So whenever you see a light blue crest or a white opaque substance, it is intestinal metaplasia. So once you have intestinal metaplasia in your place, now you are in the right position to diagnose suspicions of neoplasia. Now what are the neoplasia? The neoplasia starts from, there can be irregularities which can be even regular. So all benign lesions have regular shape, while the malignant will start having an asymmetrical shape. There will be uneven surface, there will be asymmetrical phase, heterogeneous, but they will be well demarcated. If you see this polyp, which is very regular, it's benign. This ulcer, if you make a cross line here, all quadrants have equal distribution. This is benign. And once cancer develops, it does not follow any rule. It grows haphazardly. And then it will not follow any symmetrical pattern. So this is about on the white light. Whenever you see atrophy, intestinal metaplasia, you must see a demarcation line. What is demarcation line? I will tell you. Once demarcation line is present, that means the cancer is developing. Like suppose this is a case where we saw a white light endoscopy, there is background atrophy, then there is a shape which is developing. And then you can see this shape is slightly irregular. And then there is a demarcation line. Something which was regular and suddenly there is an irregularity appearing in the surface, shape. So this is demarcation line. And once you do the demarcation line, further imaging will tell you. So this is one of our video. We can see white light endoscopy, there is some surface irregularity, and then once you zoom, there is a demarcation line. And within the demarcation line, you will start seeing irregular vascular pattern and surface pattern. So this is early gastric cancer. Early gastric cancer limited to the mucosa and submucosa. This is again an early gastric cancer. You see here there is a atrophy, complete atrophy there, and on top of it there is development of cancer. So always see this background mucosa. So whenever you see a background mucosa of atrophy, you must spend time to diagnose this type of nodular lesions or early gastric cancer, which can be easily found out. So these are very, very important thing, and also these can be treated. I have a talk tomorrow which I will discuss. But see this, This is a very well prepared endoscopy. No mucosa, every mucosa is being seen, and then this stomach is fully inflated. And I will ask you, is there any problem here? Any problem in this? Or it's looking normal? Normal. Then what is the problem? So we'll see that. See that how important it is to spend some time. I can see from a distance there is some reddish spot here, reddish spot there. So I'll zoom now. This is a black cap. I'm using the endoscopy, narrow band imaging, and you can see a 2 millimeter cancer there. This is a 2 millimeter cancer. And this is, once we take biopsy, it's undifferentiated cancer. So once you have an undifferentiated cancer, you must take biopsy 1 centimeter all around this nodule, because undifferentiated cancer spread subepithelially. Mucosa may look normal, but the cancer is below. So you cannot remove just this nodule and be happy. You must take biopsies, all 4 quadrant, 1 centimeter above this nodule, and do endoscopic submucosal dissection, which I will not talk today. Tomorrow we will talk about this. In esophagus also, you can see this white light endoscopy may be passed out as a normal. But if somebody is very careful, spending time, I am seeing this is the posterior wall, this is the right atrium which is hitting here, and then I can see some difference in the color. When I shift to narrow band imaging, this is the normal esophageal mucosa, this is abnormal esophageal mucosa. And once we go in more detail, see that these are the IPCLs, intrapapillary capillary loops, which are dilated, which are forming a loop. Whenever you find a loop forming IPCLs, this is very early cancer. So you can do a good ESD and remove it, and then these patients become perfectly fine. Always spend some time. And this is a case of a Barrett's esophagus. Now you see that this is a Barrett's esophagus, here is the Barrett's, and there is a nodule. So this is non-dysplastic Barrett's. So Barrett's can be dysplastic and non-dysplastic. Once there is a non-dysplasia, don't touch that. But once you have a nodule which is showing a cancerous, because these are pre-cancer condition, all the visible nodules from the Barrett's should be removed by ESD, endoscopic submucosal dissection. So you saw how meticulous examination pick up these cancer. But we should know what is normal, what are the precursor lesions, atrophy, intestinal metaplasia. They are not yet cancer, but you may call these patients more often, 6 months, 1 year, to do a meticulous examination, so that you can catch these ulcers, cancers early. But if you don't wait for the cancer to develop, so ultimately once we have a good endoscopy done, we must have a good report. Type of endoscopy procedure you have done, date and time, name of the endoscopist, assistant, small history about the patient, indication of the procedure is most important. Even if it is done for dyspepsia or screening, we must write. Comorbidities, consent, sedation used, other medications, especially antithrombotics, antiplatelets are very important things to be known. I have done a biopsy and the patient bled so much that he was shifted to ICU for 3 days because he was on dual antiplatelet. Extent and completion of the procedure, whether you are able to do that, relevant endoscopic finding, adverse event, patient comfort during the procedure, final diagnosis, then pathological specimen which you have sent, proper documentation and labeling of the, and then follow up. And suppose there is a cancer in the pathology, there should be a documentation that how to inform the patient, how to call the patient, and these are some of the things which we must do. And this is was a talk on basic endoscopy, and I'll stop here. I've crossed my time, but I think this is the way. This is actually I feel that we must match our Japanese or even Chinese colleagues, even South Korean colleagues, to diagnose these cancer in early stage. If you diagnose these cancer early stage, you can do organ preserving endoscopic surgeries with a very high 5-year survival rate. So we are doing a lot of educational activities in our institute. You are most welcome to join. We do every 2 to 3 months, but also dedicated live workshops every 1 or 2 years where you can come and join and learn. Thank you very much for your patient hearing.
All the aspects of endoscopy, and certainly I believe that the standardization is the need of the hour.
Yes.
But it requires a massive nationwide effort led by premier institutes and Society of GI Endoscopy. And even here, I think there must be about 100 people doing endoscopy in Bhopal, but we have so few here. It needs a lot of effort, lot of involvement of people.
Yes.
You have very nicely covered, since the live cases are already waiting.
Yes, yes.
So I've been told by instructors, the organizers, to wind it up today. And the question answers can go on in between whenever.
Thank you so much, sir. I apologize.
Thanks, Mohan. Thanks for being so nice. Thank you.
Thank you so much, Mohan. That was an excellent talk. In fact, we should have more and more of such talks in future to improve ourselves in terms of reporting.